Antihemorrhagic agents. Today we will discuss antihemorrhagic agents, which are used to stop bleeding. These agents are commonly utilized after surgeries, following trauma, or as a treatment for anticoagulants effects. One key point to focus on is the relationship between antihemorrhagic agents and anticoagulants. Anticoagulants are known for breaking down clots or preventing their formation, thereby maintaining blood fluidity. On the other hand, antihemorrhagic agents aim to stop bleeding by promoting coagulation, effectively preventing clot breakdown. This makes antihemorrhagic agents the antidote to anticoagulants. However, antihemorrhagic agents require monitoring to avoid complications such as thrombosis, embolism, deep vein thrombosis, which is abbreviated as DVT, anaphylaxis, or hypotension. Antihemorrhagic agents are divided into 5 categories: tranexamic acid and aminocaproic acid, which prevent plasminogen activation; natural or biological agents, such as protamine sulfate, which is used as an antidote for heparin; vitamin K, which is the antidote for warfarin; direct biological agents, such as idarucizumab; bullet blood transfusion, including plasma or platelets, which is a simple solution for treating bleeding under specific conditions. We will not discuss this today. Aminoproic acid and tranexamic acid. These 2 drugs are antifibrinolytic agents that prevent fibrin breakdown. Mechanism of action. These drugs inhibit the binding of plasminogen to fibrin, preventing plasminogen activation and thereby stopping clot breakdown. Tranexamic acid is 10 times more potent than aminocaproic acid. Methods of administration. The drugs can be administered orally or intravenously as needed. Dosage control is preferred, especially in urgent cases like severe bleeding. Metabolism and excretion. Both drugs are excreted almost unchanged in the urine. Potential complications: thrombosis, deep vein thrombosis, hypotension. Monitoring and follow-up. Patients using these drugs should be closely monitored to avoid serious complications. This includes periodic blood pressure checks, monitoring D-dimer levels to assess clot stability, checking kidney function to ensure proper drug excretion. Clinical use. These drugs are primarily used after surgeries that increase fibrinolysis activity. Tranexamic acid is preferred in more severe cases due to its higher efficacy compared to aminocaproic acid. Protamine sulfate. Protamine sulfate is a drug used as an antidote to heparin and is commonly extracted from fish, for example salmon, or animals such as bulls. Mechanism of action. Protamine sulfate works by binding to heparin to form an inactive complex, reversing heparin's anticoagulant effect. The resulting complex has no anticoagulant activity, thus helping to stop bleeding caused by excessive heparin doses. Method of administration. Protamine sulfate is administered intravenously, but it must be given very slowly to avoid severe allergic reactions, which are known as anaphylaxis, low blood pressure, or bradyarrhythmia. Metabolism and excretion. After administration, protamine sulfate is metabolized in the liver and excreted by the kidneys in the urine. Potential complications: anaphylaxis, severe allergic reactions; hypotension, bradyarrhythmia; flushing, which is skin redness; monitoring during treatment. Patients should be carefully monitored during administration of protamine sulfate. Monitoring includes activated partial thromboplastin time (APTT) to ensure heparin reversal, blood pressure checks, watching for signs of allergic reactions or hypotension.
Idarucizumab is an antidote used to reverse the effects of dabigatran. Idarucizumab works by directly binding to dabigatran, thereby neutralizing its anticoagulant effect. This antidote is administered intravenously and is considered safe when used with careful monitoring of the patient to avoid any potential complications. The main complications associated with the use of idarucizumab include the risk of thrombosis. It is a monoclonal antibody specifically designed to reverse the effects of dabigatran. Vitamin K is the antidote for warfarin, reversing its effect. It activates clotting factors, especially factors 2, 7, 9, and 10. Methods of administration. Vitamin K can be given orally, intravenously, IV, or subcutaneously. However, the subcutaneous route is less preferred due to poor absorption and slow onset of action. In emergencies, IV administration is preferred, but it must be done slowly to avoid side effects, as with protamine sulfate. Metabolism and excretion. Vitamin K is metabolized in the liver and excreted via bile and urine. Monitoring. It is essential to monitor patients using vitamin K through tests like prothrombin time, PT, and international normalized ratio, INR, to assess its effectiveness in reversing anticoagulant effects. Finally, this table summarizes what we said.